Vera's technique. Pulmonological patients are generally in poor general condition, with reduced vital reserves of the lung, poor lung capacity and limited lung function, and therefore present a risk from the anesthesiological point of view. Interventional procedures are usually performed under rigid bronchoscopy. A new and gentle ventilation technique for flexible bronchoscopy developed by Dr. Veres and Dr. Slavai is being used since 2008 at the Krems Clinic. This ventilation technique has been routinely used thus far with no complications in nearly 500 patients. Within the hospital, the method is known as the Veres method. A so-called jet converter is connected to a commercially available laryngeal mask, and the patient is ventilated by the supraglottic approach. The flexible endoscope, or the endobronchial ultrasound probe, is introduced through the jet converter. Continuous and sufficient ventilation with no temporal limitations is ensured throughout the procedure. Anesthesia is delivered under intravenous administration of hypnotic and analgesic agent without muscle relaxation, because the technique does not require overextension of the head, as is the case when a rigid bronchoscopy is performed. Thus, patients with limited mobility and symptoms in the cervical spine can also be investigated in a very gentle manner. A further advantage of the technique employing the jet converter is that injury to the trachea, the tracheal region or the glottis secondary to the supraglottic position of the laryngeal mask can be avoided. Thus, ventilation of the patient through the jet converter provides optimal conditions for therapeutic manipulations, such as recanalization, the treatment of benign or malignant stenosis, laser therapy, cryotherapy and argon plasma coagulation, as well as electrocoagulation or brachytherapy.
Durch diese Methode haben wir die Erfahrung, dass die Risikorate viel niedriger geworden ist.
With this method, we have made the experience that the rate of risk becomes much lower and more comfortable for the patients than by rigid bronchoscopic procedures. The anesthesiology is not so deep as in comparison to rigid bronchoscopy with relaxations. At least the outcome for the patients is much better. Diagnostic procedures with the endobronchial ultrasound are usually performed by patients' spontaneous breathing. In this case, the efficiency and success will be strongly influenced by the breathing excursions of the lung. The supraglottic ventilation with jet converter and larynx mask allows a precise adaptation of high-frequency impulses with smallest tidal volume. Superponated high-frequency jet ventilation ensures optimal contact with the wall of the trachea, which is especially important for lymph node punction or diagnosis with EBUS, and guarantee optimal working conditions. Although the patients investigated by this procedure usually present with reduced lung compliance and limited lung mechanics and are generally difficult to ventilate by conventional ventilation procedures, satisfactory oxygenation and ventilation in all phases of the intervention have been achieved by the use of superponated high-frequency jet ventilation. From my point of view, I will recommend this comfortable method.